I appreciate the invitation from Dr. Comina to join all of you at the conference today. Last year, we discussed that it was an extremely difficult time for our communities and our nation and the world. Not only as we were and still are confronted by COVID-19 and its economic and social reverberations, but also as we struggle to continue to promote justice and prevent HIV. I believe that over the next year, in the short term, we will continue to be challenged by massive numbers of COVID-19 cases. However, there is hope, if not expectation, that by this time next year, we will be over the brunt of the pandemic and mostly faced with our normal worries and our normal daily opportunities for making positive change in the world. Perhaps a bit wiser, more weathered, but also with some scientific technologies in hand, and with the full support of a strong movement for racial and social justice having our backs in public health and beyond. The COVID-19 pandemic has amplified long-standing systemic health and social inequities that have put many people of color at increased risk of getting COVID-19. In many cases, the same inequities that increase the likelihood of getting HIV. In 2019, there were approximately 3,500 new diagnoses of HIV in the US. While there has been success in decreasing HIV incidence over time since the height of the epidemic, HIV continues to be a disease of disparity. Many long-standing. 70% of new HIV infections occur among gay and bisexual men, who make up only 2% of the population. And among those in MSM, 39% are among African Americans. About 1% occur among transgender women, who, although small in absolute number, are also deeply affected, with prevalence, incidence, and disparities similar to MSM. Due to efforts of many people in this room, as well as the broader HIV community, there has been substantial progress in reducing HIV incidence among young African-American gay and bisexual men, with a 43% decrease among those aged less than 25. That is a direct result from focused effort. The group who previously had the highest rate of HIV incidence no longer does. However, rates have increased among African-American MSM aged 25 to 34 and are stable for those older than that. So African-Americans, Hispanic Latinos, and others are disproportionately affected by HIV. And we saw with COVID-19 how quickly inequity occurs in an unequal society. We have also learned ways to improve on these inequitable outcomes and ideally prevent these disparities from occurring in the first place. It often entails discovering new science, like effective HIV treatment or PrEP, but it also requires that innovations occur in service delivery, policy, and the use of social and economic systems to support rather than hinder progress. Is it a surprise that the highest rate of new HIV infections occur in the southern US, accounting for more than 50% of new infections? But HIV is not higher everywhere in the South, nor among all populations. Some areas try harder and some succeed. Stigma, homophobia, and discrimination put people at risk for multiple health problems and can affect whether they receive high-quality health services, including HIV testing and treatment and prevention. For example, CDC published a new vital signs report in November that shows Black and Hispanic, Latino, gay, and bisexual men were less likely to receive an HIV diagnosis, be virally suppressed, or use pre-exposure prophylaxis compared with white, gay, and bisexual men. Although there has been recent progress in reducing the disparities in viral suppression and PrEP use. CDC is working with partners to scale up science-based HIV treatment and prevention strategies in innovative ways that reach populations equitably. And COVID-19 has worsened the situation for all of us. Not only have we suffered from the effects of the pandemic itself, but distrust in institutions and people, colleagues, and leaders has been exacerbated by large forces like social media, racial inequity, and political rhetoric. We are polarized, and this has resulted in increased skepticism of traditionally trusted institutions, such as CDC and the FDA, the very ones that are involved in the response to COVID-19 and HIV, and whose success requires trust. To do well, we will need to actively work with the communities most affected by HIV inequities, create transparent plans, implement them with community members and organizations, and do a good job ameliorating the effects of the root causes that drive inequality. In 2021, CDC awarded $117 million to state and local health departments to help rebuild and begin to expand HIV prevention and treatment. The awards are part of the Ending the HIV Epidemic in the US initiative, which funds 57 priority areas that have over 50% of people with HIV in the country to expand and tailor key prevention strategies to community needs. This is the second major round of CDC funding delivered to state and local health departments as part of the initiative, and it builds upon our initial investments. And the funds will be used to expand access to the initiative's 4 major strategies and reduce health disparities. Beginning in 2021, CDC started awarding a total of $210 million over 5 years to 96 community-based organizations to implement program components that follow the EHE pillars: diagnosing, preventing, treating, and responding to HIV. This funding will help CBOs develop new and enhance existing strategies focused on populations disproportionately affected by HIV, which include gay and bisexual men who have sex with men, people who inject drugs, and transgender persons. And a minimum of 75% of clients served must also be racial or ethnic minorities. CDC has also recently finished the Thrive project in cities highly affected by HIV, including Birmingham and Baltimore, Washington, D.C., New Orleans, New York City, Philadelphia, and Virginia Beach. This demonstration project built community collaboratives to provide comprehensive HIV prevention and care for high priority at-risk populations, including Black and Hispanic, gay and bisexual men, and transgender women. And over a 5-year period, Thrive provided services to 12,000 people. PrEP prescription rates increased with co-located HIV testing and PrEP service models, and there were decreased rates of HIV diagnoses in Black and Hispanic, MSM, and transgender women in Thrive-funded jurisdictions compared with non-Thrive-funded jurisdictions. So the program worked. Trust is a gift that should be nurtured over time. And Bayard Rustin said, "The proof that one truly believes is in action." In HIV, we reduced incidence by over 75% since its peak in the mid-1980s, and we have seen some partial reductions in the most glaring disparities, but there is more to do in front of us. In 2019, nearly 23% of the 1.2 million people estimated to be eligible for PrEP were prescribed it. This represents substantial progress. A few years earlier, it was 3%, but whites remain the most likely to be using PrEP. I believe we are at the cusp of a sea change for PrEP. Today, a growing array of PrEP options is available. The FDA announced last month the approval of a long-acting prevention medication, cabotegravir, which only has to be taken by shot every 2 months. And there are medications in late-stage trials that would be taken orally once a month, or provided an implant that would only have to be changed once a year. These innovations will make it much easier to take PrEP and ART2, and will help make HIV a part of our lives, but not the main issue of our lives. CDC is working with partners to expand efforts to ensure that anyone who could benefit from PrEP can get it. When the COVID-19 pandemic began, there were substantial decreases in provision of HIV testing, but we adapted. The Ryan White program actually reported improved viral suppression rates recently compared with 2 years ago, because we were able to embrace telehealth and make prescription renewals and administrative burdens easier. Many jurisdictions scaled up HIV mobile and self-testing activities. And in 2021, CDC distributed more than 100,000 HIV self-test kits through the internet and dating apps. And because we focused outreach, they were ordered online at no cost by populations most affected by HIV, especially Black and Hispanic MSM and Black women and trans women, many who had never been tested before. So in closing, Alvin asked what I thought of the fact that several effective COVID-19 vaccines were developed and approved in less than a year. And what did that mean for HIV vaccines? So although I'd like to ask Dr. Goodnow and Dr. Fauci that same question, I think what it says to us is threefold. First, where there is a will, resources, and scientific ingenuity, we can achieve remarkable outcomes. Second, HIV is a tough virus. It mutates rapidly, it attacks the immune system, it incorporates itself into our genome, and it carries with it the stigma of sex and drugs, and everything is harder because of that. And third, mRNA technology is remarkable, and there are already laboratory studies that show promise for an mRNA-based HIV vaccine in animals. Not as effective as COVID vaccines against that virus, but substantial. And because the technology can be adjusted rapidly, I have more hope than I have ever had before that an HIV vaccine is at least on the horizon rather than a solar system away. And lastly, I just wanted to mention that I hope that that you can care for yourselves and others. COVID-19 is divisive, and so are many strains of America these days. In 1977, James Baldwin said, "People can cry easier than they can change." And he also wrote, "Those who say it can't be done are usually interrupted by others doing it." I think we have been sad and we have been frustrated for a long time. I will continue educating, organizing, and advocating for public health and social issues that impact the African American, gay, and trans communities. During this time of isolation, let us check on each other, encourage, and care for each other. Our goal is to end the HIV epidemic and to do it soon and together. Thank you.